Hi, my name is Yucai Wang. I'm a lymphoma doctor at the Mayo Clinic. Today we're going to talk about mantle cell lymphoma. So mantle cell lymphoma is a relatively uncommon B-cell non-Hodgkin lymphoma. It is a heterogeneous disease, which means patients may have different presentations at the time of diagnosis. The treatment can be challenging, and with today's available treatment, this disease is generally considered incurable. So it is important for you to see a specialist with expertise in this disease so that you can get the best care possible. So if you have mantle cell lymphoma that was just diagnosed recently, several things that would be important for you. One is to confirm the diagnosis. As I said, this lymphoma can be heterogeneous. Patients can have different forms of mantle cell lymphoma. Some are slow growing, some are fast, and some even can mimic other lymphoma subtypes. So it is important to have an accurate diagnosis. Some patients may need a repeat biopsy if the initial biopsy was small. It is critically important to confirm we are indeed dealing with mantle cell lymphoma other than some other lymphoma so that you can get the best treatment. The second thing is to have a complete staging, which means we will need to run scans, maybe additional biopsies such as bone marrow biopsy to know how extensive your lymphoma is. That also has implications in how to treat your lymphoma. The third thing is to know whether there are any high-risk features associated with your disease. You may hear terms such as blastoid or pleomorphic variant histology of mantle cell lymphoma, or high Ki67, which means a higher proliferation index or faster growing tumor cells appearing under the microscope. Other features such as TP53 gene mutation, which is usually associated with fast growing aggressive tumors. And another thing is called complex karyotype, meaning there are multiple abnormalities in the chromosome level in your lymphoma cells. So these high-risk features are important to know so that we can tailor your therapy. When it comes to treatment, there are several questions we need to address if we see you here. One is actually, do you need treatment immediately? We come back to this heterogeneous term again. Some patients have slow-growing lymphoma. They feel well even if they were told to have this lymphoma. They often can be observed initially. Some patients on the other extreme may have very rapidly growing disease and they may feel very unwell, and they often need treatment right away. And then there are patients sitting somewhere in between. We need to figure out what's the best strategy for them. So that's the first question. Now, who don't need treatment? There are patients who have no symptoms whatsoever. No fevers, night sweats, weight loss. They don't have any palpable lymph nodes anywhere. And they feel absolutely well. Their blood count, their labs look good. So they can be observed. We have multiple studies in the past to confirm that it is safe to watch and wait to observe in this kind of scenario. Patients who have any symptoms or any lab abnormalities or any impending issues based on where the lymphoma is located or how extensive they are, they usually need treatment. The second question is how to treat. Based on the experiences in the past, we usually take two approaches for different patients. For patients who are young and fit and who we think can tolerate more intensive therapy, historically we have been offering these patients higher intensity chemotherapy. You may have heard CHOP chemotherapy. We mix CHOP chemotherapy with high-dose cytarabine-based therapy. We use higher intensity CHOP chemotherapy called Maxi-CHOP. Again, mix it with high-dose Ara-C containing regimen. And after these intensive treatment induction, we often follow with autologous stem cell transplant, using your own stem cells for treatment of this disease. There are patients who are less fit or older who cannot handle these intensive treatments. So for these patients, historically, we have been using milder chemotherapy, such as a regimen called bendamustine rituximab, or BR for short. In any of these two forms of treatment, we usually follow with a maintenance treatment called rituximab maintenance. So these are the treatments we have been offering patients until very recently. So in the last just a couple of years, there have been a lot of exciting advances in treatment in mantle cell lymphoma, specifically incorporating newer agents to combine with the chemotherapy approach, specifically something called BTK inhibitor, it's a pill form where patients can take every day. When we combine a BTK inhibitor with chemotherapy, we can often reduce the therapy intensity for younger and fit patients who would otherwise need high-intensity chemotherapy and a transplant. Now we can just give them chemotherapy combination with BTK inhibitor. Many patients can omit the stem cell transplant part. We have some study that suggests that we can even lower the intensity of the chemo part. So potentially we can use a BTK inhibitor with lower intensity chemotherapy for these patients who historically needed very intensive treatment. For less fit or older patients, we can simply add a BTK inhibitor to the BR regimen or the bendamustine rituximab regimen. That has improved the outcomes compared with chemotherapy alone. And also, we need to keep an eye on what's coming for this disease. So we have moved from chemotherapy alone to now chemotherapy in combination with novel agents. So next step we are trying to reach is to use novel agents alone without chemotherapy. And these studies are actually ongoing, and we are involved in those kind of studies. So hopefully in the future we can get rid of chemotherapy and just give you pills and immunotherapy infusion-based therapies. We are also moving other exciting therapies, in addition to BTK inhibitor, to the very front line of this disease treatment. For example, using bispecific antibody, which is an immunotherapy, and also maybe even CAR T-cell therapy in some patients.
I want to express our sincere thank you to our patients, to the members of our Mayo Clinic Lymphoma Disease-Oriented Group, to the Mayo Clinic, and to the Goldman Philanthropic Partnerships for this generous gift to produce this series. This gift has an incredible duality in that it goes directly toward enhancing patient care and provider education. We are at a time of phenomenal rapid change in the treatment plans, the biology, and approaches to clinical care in patients with lymphoproliferative disorders. This project will serve to inform. Again, our sincere thank you, and in the words of Dr. William Mayo, quote, "The needs of the patient come first."